back.
Thank you. The gentleman yields back, and the chair recognizes Mr. Pfluger for 5 minutes.
Thank you, Mr. Chair. I appreciate you letting me wave on, and to all our witnesses, thank you. I represent a rural district. It's about 320 miles from east to west, and a lot of rural areas. And in fact, in the back here, we've got some healthcare professionals from Texas Tech University, and we have worked with them in the past couple of years to improve access to telemedicine. They have some phenomenal ideas about how in public places and with schools that they are partnering, and we're very proud of the work that's being done. I'll start with Dr. Schwam, and these questions probably have been asked in some areas, but please forgive me if they haven't, and expand if they have. But in which areas have you seen demonstrated effectiveness in enhancing healthcare access in rural communities?
I think one of the most profound ways in which expanded access has affected rural communities is in some of the programs we've discussed earlier, like telemedicine for acute stroke care, where we're largely connecting facilities in rural areas that do have adequate broadband connectivity to urban and academic healthcare systems that can provide instant access to life-saving and disability-reducing therapies. There's no question that that's been incredibly impactful. I think also the use of audio-only telemedicine visits to support individuals with behavioral health issues or with opioid use disorders has been a lifeline in this country. And I think even just the fact that healthcare can be delivered into a rural community so that a 30-minute visit with a primary care doctor or a specialist requires 40 minutes of commitment from the patient, 5 minutes before, 5 minutes after, instead of 6 to 10 hours out of their day, arranging elder care, child care, losing income from being away from their job. If we lived in a patient-centric healthcare system, that wouldn't happen, and we wouldn't have things like waiting rooms, right? We live in a provider-centric healthcare system, and we need to change that.
Please go ahead.
I just wanted to add one thing that, well, one of the things in some work that I actually did with Dr. Schwam really highlighted that both the benefits in rural communities for a program like Telestroke, but also something that hasn't come up here is that the hospitals that benefit the most from that technology, those in small rural communities, are often those that are least likely to have that technology available. And in our conversations with CFOs of those hospitals, it's often that they don't have the resources, the cost, upfront costs that cost to devote to that services. So I think as we think about the huge benefits we can see in rural communities, there may need to be targeted investments to support those hospitals to invest in a technology like Telestroke, because right now, unfortunately, it's not happening.
Thank you very much, Dr. Cunningham. When it comes to, I guess, in what ways has the removal of either geographic restrictions or the originating site limitations facilitated the enhanced access for rural communities? And feel free to expand on the previous question as well.
Is this specifically related to the licensing question?
No, just in general. Yeah.
The originating site.
Yeah.
For the clinician or for the patient.
Removing the original.
For the
Yes.
access. For this. Oh. Yeah. How does that impact the access for rural patients?
Well, it's having that in place creates a significant barrier for us to be able to deliver the care. So, it really doesn't make any sense to have that restriction in place. And we've been able to demonstrate that through the pandemic and beyond. So I would suggest that we not go back in time to that place.
So for anybody on the committee, because we have the Texas Tech University Health Science Center folks that are here, and we're working closely with them, just any thoughts, ideas on what it means to have a public-private partnership, on universities participating in this, and then how that impacts the cost? And I'll start down here with those that we haven't asked questions to, but we've got about 40 seconds left.
I think, just to back up what Dr. Cunningham just shared, I think the most minimal thing that can be done is to waive the originating site restriction. We want to expand access to people who are receiving care at FQHCs, at rural health centers. Also important that people can receive the care at home. And I just want to also make a point that half of beneficiaries are living on very low incomes of $30,000 or less. So we have to be really careful with those, with any charges they might incur.
Very good. My time has expired. Thank you for being here. I'm sorry we didn't get a chance to complete the panel, but I yield back.
Thank you.